Howdy, my name is Tom Weiss. I'm a geriatric psychiatrist, and I've been privileged to be asked to give a presentation today with a rather attention-getting topic called Taking Care of the Hateful Patient. So I have to begin by letting you, the audience, know that I'm in a highly agitated state, because here in San Antonio, our beloved Spurs tonight enter Game 7 against the Miami Heat, and there's this electric atmosphere in our city. So I just want you to know I'm very fragile, and perhaps as we go along I may just burst into a Go Spurs Go chant. So thanks for your kindness. I was trained by Jesuits, and they insist that whenever I do a presentation, I have to tell a story or two, and I must introduce pieces of history, or I'll be struck down by a Jesuit lightning bolt. So we'll begin with a wee story. You heard about the Georgia Peach, a woman in Georgia. It was a lovely Sunday afternoon, sunny, blue skies. She decided to go for a drive in the country. She's cruising along, and she gets to a bridge over a large river there in Georgia, and she spies this young man, about 25. He's perched on the bridge railing, and she immediately pulls over to the shoulder and jumps out of her car because it looks like he's going to jump off and take his life. And she yells to him, "Please don't jump. Think of your wife and children." And he yells back at her, "Lady, I'm not married, I don't have any kids, I'm jumping." So quick thinking, the Georgia Peach yells out, "Please don't jump. Think of your mother and your father." And he says, "My parents are dead, I don't have any brothers or sisters. Leave me alone, I'm jumping." And then finally, out of sheer desperation, the Georgia Peach yells over, "Please don't jump. Think of Robert E. Lee." And the young guy, he's peeved, he's irritated, but now he's puzzled. He looks over at her and he says, "Who's Robert E. Lee, lady?" And she yells back at him, "Why don't you jump, you Yankee SOB?" So I tell that story because it's a lovely example of what we in psychiatry like to call countertransference, meaning the feelings that the physician or the caregiver has toward the patient during the encounter. And here's this Georgia Peach trying desperately to rescue this young man, and she's rebuffed, and then finally at the tail end she kind of reveals another side of her, kind of a human side. That's why we grin. So the title today is fairly politically sensitive. In fact, I was worried that Morningside Ministries might want me to take out the word hateful and substitute the adjective difficult. But instead, they told me that they actually worried more about the word patient. And they debated it, and long story short, they decided to keep it. And I'm glad we did, because when I started my fellowship training, the very first day that I met my mentor, he asked the other two fellows and myself, day one, minute one, he said, "What's the origin of the word patient?" And of course none of us knew, so we got our first homework assignment before 30 seconds had passed. And if you look up the word patient, you'll discover it's from the Greek, and it's simply to suffer, to suffer. And all of us, when we've been unwell, physically or emotionally, very few of us, when we're unwell, are at our best. It's often said that doctors and nurses in particular make the worst patients, and I think that might be true. And of course, when we're not at our best, it's pretty difficult for other people to love us, sometimes difficult to even like us. But we're not going to talk today about the occasional personality clash between a care provider, a clinician, a physician, and their patient. But we're actually going to talk about patients that kindle dread. But we're going to try and make this very productive. As you can see in my subtitle, this very short slide review is going to be a guide to enlightened hatred. So remember the Jesuits, they insisted that I always introduce pieces of history. So in 1682, a now famous English physician named Thomas Sydenham, he's probably most notable for describing in impeccable detail a neurological condition that today bears his name, called Sydenham's chorea. But in 1682, after working with a population of what in those days were called hysterics, these were difficult patients that were impulsive, unpredictable, and would evoke a lot of negative feelings, Dr. Sydenham wrote the following quote, and you know, it's just beautiful in the prose. It makes me wonder why we don't write this way anymore, but I mean, it says it all in a sentence. With this population of difficult patients 330 years ago, he said, all is caprice. Translation, anything is going to happen here. It's very unpredictable. These patients, these hysterics that he's treating, love without measure those whom they will soon hate without reason. So here's a patient that it starts off lovely, but very quickly becomes very, very ugly and difficult. And you know, if you can read between the lines here, I think what you detect from Dr. Sydenham 330 years ago is a bit of bewilderment and trying to figure out what to do with these folks. So this isn't something that started last year or this century. This is part of humankind and caring for one another. But again, the Jesuits are very precise folks, and they insist that you always start off a presentation with a definition. So this is the good Merriam-Webster, and it's simply hate. Intense, let's focus on the adjectives here, hostility, and aversion, a word that I don't use much in day-to-day language, usually deriving, and here's where I want you to really post up and remember, deriving from fear, anger, or a sense of injury. So if I pause and I ask you in the audience to just step out of your nice social selves and just for one moment ask yourselves, who or what do you hate right now? I bet you can come up with a pretty good list pretty quickly. I mean, maybe if you're politically driven, you might say, I'm not so sure about that Kim Il-jong guy, and gee whiz, that Osama bin Laden, I'm glad we're rid of him, good riddance. Maybe you'll be more current and say, I just detest those cowards and those fiends that engineered the Boston Marathon bombings. Or maybe the gunmen that massacre innocent first graders and their teachers. I just hate souls like that, evil souls like that. Or perhaps if you're a little more genteel and you live in San Antonio, you might say, golly, I really dislike and sometimes I just hate NBA referees, or I hate those all-star players on the Miami Heat. But it's something that we can kind of quickly identify with. We all know what it is when it's upon us, and it's very much a perceptible feeling. But I want you to remember as we go through the rest of the slides, those words that you see right now, aversion, fear, anger, and sense of injury. So, hateful patients evoke negative feelings in the caregiver. Now you might say, well, this is an obvious statement. You know, this is intuitively obvious. But we're going to expand this, and you know, I realize that the audience that I'm chatting with today are primarily caregivers and clinicians who are working with patients, elder patients, most of which have a dementing illness. And I was thinking, how can I kind of apply this presentation to that population? And the first thing that came to mind is a long, long time ago, I was told, and I think it's true in a general way, that, you know, we all have particular eccentricities and habits. And as we get older, quite often those habits become, and eccentricities become a little more coarser, okay? So if I'm a young, obsessive guy, maybe as I get older, I'll be an old, grouchy, obsessive guy. And when we're talking about negative feelings, let's go cut right to the chase. And you know, I think we all can identify with these feelings if you just think about perhaps a patient, or maybe even a neighbor, or someone in a service industry where you've started to go from something's wrong here to I just don't like what's going on in this relationship to I just hate what's going on. And I'll bet when you notice that someone has evoked in you a sense of hatred, okay, quite often this is the follow-on for you, the caregiver, for you, the customer, for you, the neighbor, for you, maybe even the family member. I mean, certainly sometimes family members can evoke in us very strong negative feelings. But this is what we see in the medical world. When hateful patients that we dread, we're working with them and they evoke negative feelings in us, quite often what we see first and foremost is sometimes the care provider, the clinician, becomes paralyzed, you know. Maybe they begin by trying to help this patient too much, and that fails. And then they resort to maybe the bare minimum, and that just pours kerosene on the fire. So quite often there's a paralysis, if you will. Things kind of come to a stop. There's a malfunction in care delivered. And, you know, of course, things can always get worse, can't they? That's part of the lesson of our time on this planet. That's the lesson of life, that things can always get worse. So sometimes these negative feelings can go to the next step where the care provider, the clinician, may unconsciously punish the patient. I'm furious at you right now, so we're going to give you your medicine for pain a little later. Not right now, you know. And I'm not saying that this is necessarily conscious. It's primarily unconscious. Sometimes it is conscious. There can be punishment. Usually it's in terms of not active punishment, but more passive withholding. Third bullet, you know, what's the famous quote by Bill Clinton? The worst wounds are the ones that are self-inflicted. The third bullet, you know, negative feelings that patients provoke in us, the provider, or us, the caregiver. Sometimes we leave the encounter saying, wow, I'm a bad doctor, I'm a bad caregiver. If I was only better, if I was only more noble, if I had thicker skin, if I didn't let this patient get to me, then I wouldn't be feeling the way I'm feeling. So we beat ourselves up. And I don't know about you, but when I beat myself up, I'm no good to anybody, including myself. And then the fourth bullet, and you'll see this more often than not in emergency situations. This is where things have gone wrong from second one, and they go from bad to worse, and worse to ballistic, worse to catastrophic. And you know, the typical picture is the emergency room doctor, you know, telling the patient that they're a crock and they don't deserve any treatment, and kind of resulting in bullet 5, get out of my emergency room, where the patient is now extruded. So what's the sum of this? The sum of this is the patient doesn't get the care that they deserve and that they need, and the caregiver suffers as well. So this is truly the double-edged sword if we don't pay attention to this and fix it. So it's very interesting in the medical literature. You know, in medical school, I think I had 50 hours on the Krebs cycle, which I've never used in 32 years of practice. And I think I had 1 hour on the difficult patient. And my recollection of what to do with the difficult patient was, if this difficult patient evokes strong feelings in me, I should transfer their care to probably a colleague I don't like very well. And that was sort of the sum of it. But it's a funny thing in medicine, you know, we're often given very lofty goals to aspire to, and that's fine. I mean, what's the quotation? Man's reach should exceed his grasp, or what's the heaven for? This Latin word, equiminitas, is actually the motto of Johns Hopkins Medical School. It's on their crest and their tie and scarves. And this term means imperturbability. I'm sure I massacred that, meaning coolness under fire, presence of mind no matter what is going on, what chaos is arising, clearness of judgment in moments of grave peril. This was coined by Sir William Osler. He's sort of the father of internal medicine. And he actually wrote an essay on this in 1933, and he said, this should be the premier quality of a good physician. And you know, I love the last sentence. According to Dr. Osler, he said, you know, physicians should have this quality. And in many ways, it should be a divine gift. You know, I almost feel like there's a beam of light coming upon us. And it's a blessing to the possessor. And for that singular noble individual that has this quality 24/7, you know, he or she is a comfort to all who come in contact with them. Well, you know, I think that's absolutely lovely. But the last time I checked, I'm flesh and blood, okay? And another piece that's often presented in medical training, it's called the Faustian ideal. Remember, Faust was a healer. And it's simple. Know all, love all, heal all. Wow. I'll just say these are very, very tall orders. And in fact, I'm pretty sure in the information technology era, I cannot know all. I hope that someday maybe I can love all, and I am convinced that I cannot heal all. But that's a separate story. But so these are the pieces, the setup, if you will. So in medical school, we're not taught much about the difficult patient, and we certainly don't hear the word hateful patient, given this background. So little has been written about this, little has been said about this till probably the last 50 years. And it all began in 1949 when a really singular physician, he was both a pediatrician and a psychoanalyst named D.W. Winnicott. He wrote a paper called Hatred in the Countertransference, and it was published in the Journal of Psychoanalysis, and he gave a presentation, and he basically said, the truth of the matter is, for him as a physician and in his conversations with other clinicians, that some patients in certain circumstances evoke in the physician, evoked in him, outright hatred. And rather than disavow those feelings, remember Mission Impossible, you know, Mr. Phelps would get the mission and they'd say, if you're captured, we're going to disavow any knowledge of you. Rather than disavow these feelings, you know, I have these negative feelings, I can't have these. I'm supposed to be that noble physician, always calm. So if I have these feelings, I won't acknowledge them, I have to get rid of them, so I'll transfer the patient. Winnicott said, no, don't do that. In fact, pay attention to these feelings, and here's the best part, use them as clues to guide management to the patient. And Winnicott, being a pediatrician, he really spiced up his presentation. He said, you know, even mothers have an occasional, inevitable dislike of their infant. And you know, when I first heard that, I was appalled. That sounded unheard of. But think of that nursery rhyme we all know, you know, about rockabye baby on the treetop. And what's the closing refrain? And down will come baby, cradle and all. What a interesting nursery rhyme, but it kind of captures that moment. So I remember being a new father for the first time, and our daughter was just terrific. I think she was about 3 months old, easy, great baby. And there was one night, my wife was away, and my daughter was utterly inconsolable, just crying, crying, crying. She wasn't sick, didn't have a fever, was dry, had been fed, burped, walking her. It was about 4 in the morning, and there just was a moment when, you know, I think I was out of gas, and I had her over my shoulder, and I remember kind of holding her out a couple feet from me, and she's wailing away, and somehow Dr. Winnicott's piece came to me just for a flash, and it scared me, and that was that. So I'll just simply say I'm human too. So long story short, again, this lecture developed from a psychiatrist named James Groves, who in 1978 wrote an article entitled Taking Care of the Hateful Patient for the New England Journal of Medicine. And this article came about when Dr. Groves took care of a young woman with borderline personality for several years, worked hard to try and get her well, and she took her life, and she wrote a long letter blaming him. And he was really stricken, devastated, did a lot of soul searching, and he ended up writing about this particular case, kind of a psychiatric autopsy, and part of it I think was also therapeutic for him. And then he went on to kind of expand, and hence this lecture. So what Dr. Groves is going to say here is that we'll encounter in taking care of patients and taking care of relationships 4 different types, if you will. And there's the 4 types: dependent clingers, entitled demanders, manipulative help-rejectors, self-destructive deniers. And these patient types evoke in us, the caregiver, the provider, very distinct negative feelings. And again, our theme here is rather than disavow these negative feelings, we want to use these negative feelings as clues to directing better patient management. So that's the process that we're going to go through blow by blow, and at the end I'll summarize it. Okay? So 4 patient types, and I think as we go along, I have a hunch that as you think about patients you've worked with who were difficult, or if you can allow yourself to say it, hateful, you'll quickly see identification. So the dependent clinger. I'm going to cheat for a minute, and I'm going to read a description by Dr. Groves about the dependent clinger. It'll just take me 30 seconds. But he's such a beautiful writer. What does they say? A picture's worth 1,000 words. So here's his description of a dependent clinger patient. A 23-year-old exotic dancer of no little beauty consulted a resident in medicine because of fatigue. The male resident was eventually able to make the diagnosis of lupus. He took care in explaining the mild nature of her particular course. She responded intelligently with questions pertinent to prognosis, and eventually asked whether he'd follow her long term for this chronic illness. Key piece here. Flattered and touched, he vowed to do so. Later that day, she telephoned to thank him. During the next week, she visited with a question about her medication, and the following week she called twice, once to thank him and another time to profess great fears she would die. As the weeks passed, her calls and visits became more frequent, and her thanks dwindled to nothing. He began to dread her calls. Please zero in on that powerful verb, dread her calls. By the end of 2 months, she was calling him daily, in the office and at home. What had begun as a minuet ultimately became a fandango. What a great sentence. What had begun as a minuet ultimately became a fandango. The resident changed programs, and soon the exotic dancer was involved in a similar situation with another resident in the same hospital. So, what does this tell us? The dependent clingers are generally patients who from the get-go are naive. Maybe they appear naive, maybe they are naive, and they're seductive. Seductive. They view the care provider as inexhaustible. I can call you anytime, several times, because it's just me that you're going to treat. And of course, if you are inexhaustible, that means their needs don't have a bottom. Okay? And did you notice, as Groves described this little vignette, at the very beginning you got a little flutter in your tummy because it sounded like puppy love, you know, when he was flattered and touched and she called to thank him. It almost sounds like a Walt Disney movie. To which I say, if you're taking care of a patient and you notice that early on, I'm not going to say, you know, get your guard up, but just pay attention to puppy love, because that's exactly what it is, puppy love. It's not enduring. So right out of the gate, we have some early signs that the patient is overly grateful. You know, anything that's too much or too little, we always want to pay attention to in life. And we've got a sign that they're, you know, putting this doctor on that pedestal. Remember Sydenham's earlier comment, you know, in the beginning, their love is without reason, or their love is without boundaries, okay, that high pedestal. So these are tip-offs to the dependent clingers, okay? So what feeling was evoked in this poor resident? Well, he changed his training program. So the feeling that's evoked by these patients in caregivers and in physicians is one of aversion. You know, the example I like to give residents is that patient that you see 2 blocks away in the hospital, the long hospital corridor, you see them walking towards you and you're looking for a bathroom to duck into. I'd say that's a dependent clinger you're trying to avoid. So here's the best part. So this patient evokes in the caregiver aversion. As soon as you notice that feeling of aversion, okay, that's a signal for how to manage them. It's kind of straightforward. Number 1, set firm limits immediately and plan on repeating them. If it's an emergency, you can get me by my answering service off duty, and I'm going to define an emergency, okay? And we're going to have scheduled appointments. All right? You're not going to give them your home phone. You know, this isn't call me anytime you like, okay? And this is for the dependent clinger. Now, there may be patients that you do give your home phone to, okay? But they're not going to be the dependent clinger. And what we want to do here is protect the patient from promises that we, the caregiver, and we, the provider, can't keep. So remember, when you start to feel like you want to avoid the patient, that probably means you need to explore the limits you currently have and review them and maybe set little tighter boundaries. The second patient type, the entitled demanders. Wow. So they're the polar opposite of the clingers. They're not naive, at least not naive in an innocent way or a seductive way. In fact, they're generally very hostile, intimidating is probably the best word, and they really like to evoke in you, the caregiver, guilt. You're not good enough. And then I love the third bullet. That adjective says it all. They are repulsively entitled. And they're often go around in a sense of, you know, not road rage. This is just rage at the world all the time. And they really like to shame us, okay? And at the bottom of entitled demanders, their religion is entitlement. So if I might, a quick vignette. This is even more glorious. A 51-year-old attorney specializing in medical malpractice was enraged when his many complaints were ultimately diagnosed as MS. Known for his courtroom pyrotechnics, he roamed from doctor to doctor, refusing to understand the nature of his illness and threatening to sue the previous, quote, bastards, end quote, who had tried to help him. He adamantly refused treatment and demanded more and more tests and consultations. Eventually, his doctors did not return his calls and were frightened and depressed about him. How long this situation might have continued is not known, because at this point, to the relief of all concerned, he was hospitalized for an exacerbation of his demyelinating disease. So you can picture this guy. He's already fear-provoking because he's a medical malpractice attorney, famous for his courtroom pyrotechnics, okay? So what feeling do entitled demanders evoke in us? Well, it's very primitive. And remember our earlier definition of hatred. They evoke in us fear. We're frightened of these people. And you know, typically, most human beings, when I think I'm going to be punched, I'm getting ready to punch back. So we want to counterattack their entitlement. You know, think about standing in line to see a much desired play or movie, and all of a sudden some guy jumps ahead of you, and you know that impulse is, hey, what, you know, how do you get that special entitlement? So they're very entitled. And Groves has a very fascinating remedy here. He says, rather than confront their entitlement and deny them, which usually leads to a vicious circle, you know, they want more, and you know the clinician or care provider says, you know, why are you special? I'm actually going to withhold, and then we get a, you know, an escalation. So Groves says, don't counterattack, don't diminish the entitlement, but instead rechannel it and use the word. I know you're entitled to good medical care. You deserve good care. Use the word entitled. Use the word deserve. You'll see it diffuses them. They're sort of like, you're speaking my religion, okay? But you're fighting the wrong people. You're fighting the people that are trying to take care of you, okay? You're entitled to good care, but you have to work with us. So don't push back on the entitlement, rechannel it. So the third patient type of Groves, he's pretty fancy in his descriptors. These are the manipulative help-rejectors, aka crocs. So these are patients, visit one, I've got a headache, their headache's treated, visit two, I have a stomach ache, their headache isn't any better, the stomach ache's treated, visit three, I've got a backache, now the headache isn't any better, the stomach ache isn't any better, the backache isn't any better. In other words, this is quite the opposite of the entitled patient. Nothing helps, okay? Nothing helps. And typically, these are patients, at least in the medical setting, their records are volume 4, okay? And multi-system problems. And if you're able to step back from these patients that have a lot of complaints, constant complaints, and sort of look at it through a different binocular, what these folks are looking for is not cure, but they're looking for care. And you know, Groves states it very nicely. He said they want a marriage in which you can never be divorced, with an inexhaustible partner. And if you cure them, if the headache's fixed, if the stomach ache's fixed, if the backache's fixed, what happens? Well, they lose this relationship with the caregiver, with the provider. And then they got to start it up again. So these folks, they're actually terrified of being abandoned. Okay? And usually if you look at your life, you look at their lives, or get a chance to look at their lives, you'll discover that they're pretty isolated. If not by choice, they're often isolated by their behaviors. So what feeling does this type of patient, where nothing helps, nothing works, everything you do fails, what does that evoke in us, the caregiver? Well, I think we go from our general eternal cheery optimism, we start to become pessimistic. You know, as a physician, I would sometimes put my head down and kind of wring my hair and gnash my teeth and say, maybe I should have gone into the restaurant business. I don't know. I'm not a very good doctor. I would feel inadequate. I'm not fixing this person. I'm not curing them, okay? But Grove says, you know, when a patient evokes in us powerful feelings of inadequacy and pessimism, that's a clue. And what will work here, and these are so spot on. Number one, share the pessimism with your patient. You're right, Mrs. Flabitz. We haven't been able to get the headache fixed or the stomach ache fixed or the backache fixed, but we're going to continue to see you regularly. There's new treatments coming out all the time. I'm going to treat you conservatively. We're going to schedule regular visits, and treatment will continue. What are we doing here? We're reassuring the patient that even though we're not able to cure them, we are going to care for them. And then I think Groves also has a nice piece in the third bullet, you know, also think very seriously that this type of patient has maybe a depression that doesn't present in typical fashion. Maybe psychiatric evaluation could also be very helpful in a collaborative way. And the last group, the most troubling, difficult group for me personally, and I'll speak on this in a minute, Groves talks about the self-destructive denier. I mean, the name says it all, okay? And again, if I can just give you the Groves version, it's a picture. So a 45-year-old alcoholic man was familiarly called Old George by members of the ER. They'd seen him more than 100 times over 6 years for a variety of physical ailments ranging from an acute GI bleed to a subdural hematoma after he fell from a ladder while drunk. It became a standing joke that the more carefully he was treated to and the more thoroughly he was worked up, the more furiously he drank. He was released from his hospitalization for the subdural hematoma on Monday, stitched up for multiple lacerations on Tuesday, allowed to sleep it off in the back hallway on Wednesday, casted for a fractured arm on Thursday, and admitted with wildly bleeding esophageal varices on Friday. The staff worked furiously through the night, pumping in whole blood as fast as it would go, but at 4 a.m., the intern pronounced Old George dead. The junior resident muttered, "Thank God," under his breath, and the senior resident said, "Amen," quite audibly. So, what a picture. These are patients, these are people, these are souls, and they're very different from those folks that have what we call healthy denial. So I grew up on the south side of Chicago, and you know, we got a lot of snow, and my next door neighbor, Mr. Flabitz, had a heart attack and he's out of the hospital, and a day later he's shoveling snow. So he's the kind of guy that has healthy denial. You can work with these folks. You can go out there and say, "The doctor does want you to rehab, Mr. Flabitz, but we're going to do it in a different, more graduated way." They have healthy denial. These folks do not. They are profoundly dependent, and from that vignette, they've given up hope, which perhaps might be, you know, the worst suffering of all, to feel hopeless. And, you know, by their behaviors, they glory in their own destruction, And anything that's done to preserve their lives, they almost work in a more potent sense to defeat. So what does this patient evoke in us? The self-destructive denier. Well, in Grove's case, he feels that if we're honest with ourselves and we can self-explore, they evoke in us malice, anger. Okay, and remember the definition of hatred earlier. And also kind of a secret wish. Well, everything I do, you undo and make worse. So what is it exactly you want to do here? I mean, we are at the end of the day, all of us, patients, caregivers, and physicians, we're flesh and blood human beings. So these thoughts do go through our head. So Grove says, with this patient population, number one, we must lower our expectations of delivering perfect care. So Dr. Osler's aquiminitas has to be adjusted realistically. Number two, he says, early on in these self-destructive deniers, whistle up psychiatry to see if important adjective there, a treatable depression exists. And then treat this patient like you would any patient with a terminal illness. Try and preserve them as long as possible. So, summary. Here are 4 patient types, okay? The dependent clinger that evokes in us aversion, and rather than disavow that negative feeling, recognize it, permit it, and allow that to guide you to set firm limits, okay? With the entitled demander, they often evoke in us fear and a desire to counterattack. Their religion is entitlement. Remember that. Rechannel that entitlement. Use the actual language. You are entitled to the best care, but this is how you will best get it. Repeat it. The manipulative help-rejectors evoke in us a sense of pessimism and inadequacy. Share the pessimism. Share the misery, odd as it sounds. I know you're still suffering, and wish we had some cures. We don't, but we do have treatments to try and relieve symptoms. Share the pessimism. You don't have to be a toxic dumping ground, okay? And then the self-destructive deniers, they evoke in us malice. Recognize that. Treat these patients as if they are terminally ill, because they are, just in a different way, because it's at their own hand. And maybe this will sum up the entire talk. And I don't know who said this. I think it's ancient. I'm sorry I don't have the source. Maybe somebody in the audience will, and they can shoot it back to me. But, at the end of the day, if you think about what we do in medicine, if you think about what we do in caretaking our patients, what we do in caretaking the people we love, the relationships we're in, well, this is what it always boils down to. I mean, these are the choices. We sure would like to cure, we'd like to fix problems, solve problems, and that'll happen sometimes, and it's wonderful when that happens. It's a cause for great joy and celebration, but we have to remember the sometimes, okay? We can relieve much more often. The truth of the matter is, medicine is, maybe life is very humbling. An awful lot of illnesses in 2013 that we do not have cures for, but we have lots of treatments and management. We can relieve often, and that's good to know, that relief is there often. And then really the last piece, though, is the one that gives me great comfort, is that even if I can't cure the patient, even if I can't relieve their symptoms, we can always comfort them, and there's a million ways to do that, isn't there? A million ways to do that. So on that note, I will conclude, and I must end, given this being Game 7. Everything's on the board tonight. Go, Spurs, go.